of all, thank you so much to the previous speaker for a great presentation. I think that's going to tie in quite well with what I am presenting. My name is Eva Kleczyk, and I'm a Senior Vice President for Analytics and Data Operations for a target RWE organization that does a lot of healthcare types of studies, working with physicians and health systems to understand the patient journey that patients are going through for multiple types of diseases. I'm also a affiliated graduate faculty from University of Maine, and as you are seeing this this logo. So what am I going to do during this presentation? What are the objectives? The first thing that I would like to discuss is introduce concepts of data and how are we measuring data for these types of projects. When we are thinking about observational studies, and Alan quite well talked about it from the academic point of view, I'm going to be talking from the healthcare sides where academia and healthcare cross bounds, and how we are analyzing the data, how we are collecting that, and ultimately what is in the data. I'm going to describe the process of selecting and engaging the healthcare institutions as well as physicians into the studies, and the types of data we are collecting as a result. Since this is a primary healthcare conference, I'm going to be discussing women's health, and I think that's going to come in a little bit more important, or very important, when it comes to talking about gender and how it impacts the healthcare choices and as well as the treatments that women have. So, as the previous speaker mentioned, it is very important to understand the gender as well as the sex of the individual who is being treated. We all know that women are cornerstone of family's health, but very often are not the ones who take care of themselves very well. So it's very important to provide the right quality of care, the right access to care, to make sure there is no disparities and biases in healthcare treatment. And overall, when we take care of a female or a feminine person within the family who takes care of the family, we can then achieve overall healthcare of the family unit as well as communities. Global efforts for women especially have been mostly focusing on improving sexual and reproductive health, which I think has been very important, and we all know the value of these services. However, in studies in other diseases like diabetes, cardiovascular, gender and sex doesn't really play into how women are being treated and what types of quality of care they receive. For example, we know that heart attacks are the biggest killer of women, and it's silent because women have very different aspects or very different symptoms, but we don't really talk about it. We don't really think about it. Physicians are yet to think about how to treat them and adjust the treatment according to how women experience certain needs and the amount of medication that they need. So with that, thinking about that, I wanted to introduce the real-world data concept, and thinking about collecting data through communities working with healthcare institutions and physicians. So one way of looking at the data is really looking at the data at the source, bringing in physicians and identify institutions that have certain types of diseases, whether it's breast cancer, whether it's cardiovascular, whether it's mental health, neurological, immunology. Women are, in many of these areas, are taking prevalence when it comes to being diagnosed as well as to being treated, and often with a much lower level of success. So when we're thinking about working with academic institutions or hospitals, we look for KOLs who are very well known in this area, because once they create a protocol and they establish the system working with women, we can then, this can be then published, as well as their KOLs, meaning key opinion leaders, they can then present their protocols to other physicians to follow. Usually when we're thinking about identifying what we call disease-based communities, once we work with these KOLs, then they can create what's called advisory committees, where we bring in industry partners, whether it's going to be pharmaceutical companies or any other clinical trials organizations, regulatory agencies. We always want to make sure that we are including regulatory agencies when it comes to any studies to provide the right protocols and garner the right data, and patient advocacy groups. We all know there is plenty for breast cancer, for mental health for women, for cardiovascular. We want to make sure that we work with these partners to understand what are the key issues that we need to resolve for. When we are thinking about creating disease-based communities, the data that is flowing in, it's looking at medical health records. In the United States, many of them are electronic, meaning you get them at the point when the patient is going into the physician office or to the network. Both the nurses as well as physicians or anyone who's supporting the care of a patient records the information, and they can be done in a structured and unstructured data. Structured being putting data into actual fields like your vitals, like your weight, and then unstructured any notes that the healthcare providers identify. Some of the data that I have the privilege working with, it goes back 3 years, and it's actually goes back 5 years, and it's prospective moving forward. Patients being tracked over time to understand how they are moving through the conditions, what are their outcomes, and they self-report them actually, and then understanding not only their medical records but also their labs, because the whole picture of having the health of the patient is very important. There's also other ways of thinking about how to create these cohorts, and this is very important as we are thinking of evaluating the larger care for family units as well as for women especially. The more information you can gather from more patients, you can then do a better sampling, and I think the previous speaker spoke about usually getting the right cohorts to get the unbiased results. So we are also looking at bringing in from the institutions we're working with all of the data they are having on these patients in the structured way, which is by diagnosis codes. As I mentioned, mental health is very important. Looking at cardiovascular, so we are not only looking at one disease, but you are thinking about the larger scope. Just so everyone knows, most of these patients are all of these patients are pseudo-anonymized, meaning we do not know their identity, and they provide consent to be in these studies. Once we have the larger disease cohorts, we can create what's called engaged cohort, and we really dive into additional information such as biosamples and what's called patient-reported outcomes, meaning when you are being put on a drug, how do you feel? When providing information on how you mentally feel, how you physically feel, are you tired, and any other questions that might be important to assessing of the patient. So once you have the data, you need to think about how do you analyze it. So this is just a generic slide that I like to go through, but think about the real data coming in from consented patients from these institutions, providing them with a platform that they can put in their outcomes on how they are feeling being on drugs, going through different procedures and so forth. For having a biorepository information, you can really fill in the insights into why patients are being put on a different therapy, why physicians are making certain choices, because you're going to understand what was their blood pressure, their blood sample, what it revealed, stool, urine, and so forth. So you can start analyzing the larger picture of a patient's health. And then you are bringing in other data sets. Due to the technology that we have available right now, linking data and getting that consented patients, as well as linking across a larger spectrum of data sets, really provides us to create analytic-ready data sets, which bring patients into a part of being a center of the analytics. And I'm going to discuss this why it's important. There is, from the analytics side, there's so many different ways of doing analysis, from very descriptive all the way through looking at advanced analytics, from machine learning, NLP, which is natural language processing, and I'm going to be talking about it shortly, to any epidemiological types of studies, patient health research studies, and so forth. So with the large data, you can really think about it, how you can analyze it, what are your questions, and really proceed. The interesting part of having, which is important when you're doing research, especially on women, because there is a lot of hidden data, is looking at what's called unstructured data. For those of you who might not know what unstructured data is, it's really the notes that clinicians put in. So very often, especially post-pandemic, during the post-pandemic COVID pandemic, women have become the cohort of studies. As many of you probably know, women left workforce at a much higher rate than men, especially at the leadership levels, the levels that I am at, where we are making decisions, we're working long hours, and it is quite stressful at times. So knowing that women now take care of the entire family unit, that their kids might be still being at home, studying from home, and taking care of elderly patients, they needed to move in with them, it created additional level of stress and responsibilities that they didn't have before. What we started seeing is that the notes that clinicians are are taking on women, especially they're treating them right now, bring in information that is extremely important. For example, the use of alcohol and cigarettes and other drugs, whether they are legal or illegal, have increased tremendously. So when a physician sees a woman that seems like she drinks a little bit more or smokes more than what she has previously, he can note it. When the physician or the nurse sees that the woman is being stressed out, they can note it. When they are talking to them and they are getting the sense that the woman, that the female or whoever is leading in the household is doing more work than was previously done before, meaning she wakes up at 4 in the morning, takes care of the child before she has to get to work, take care of elderly parents. They can know that, and they put all of that information that then helps us really understand how women are being treated, but also what are the underlying causes of some of the diseases and what should we tackle as healthcare industry in order to ensure we properly treat women, but also diagnose, especially we are on the pandemic, we are entering the pandemic for mental health. How do we take care of it? And as we know, stress can not only result in mental health issues and alcoholism and use and abuse of drugs, but it can be also related to other diseases such as cardiovascular, such as having increased heart attacks, having more strokes. The stress plays in. So I think it's very important to think about analyze the data moving forward. I mentioned to you that patients now come into studies as the center. With the increase of big data, with the ability to gather data from many different sources, and you can see it from the clinical side where we can get the data, meaning we can get it from observational studies like I just discussed, claims. For those of you who might not know what healthcare claims are, it's anytime for those of you who have healthcare insurance is the point at which you interact with healthcare and your provider submits a claim to an insurance company that is being registered. So you can really look how patients are going based on the healthcare claims as well. Provider data, any physician information or nurse information that it's there, labs and biospecimens, which has discussed how important they are in understanding the well-being of an individual, because a blood sample can tell you a lot, your urine, your stool, and so forth. So you can really start understanding where patients are. What is even more important is thinking about consumer data. I think many of you know, especially those who are living in the United States, that our credit card industry know about the patient, know about the individual, everything and anything they can know. They have the most sophisticated models, where these models will start coming in conjunction with the actual claims data, and allows us now to start looking at the overall patient as a center and seeing how healthcare is becoming part of the overall thought process for individuals. When you have to pay your bills, especially in the inflation timeframe, healthcare might seem like the least of individuals' worry until it really hits it, right? So looking at consumer data, looking at work data and other aspects really provide information that we need in order to have an appropriate way of evaluating women's health and how they are being treated and also consuming healthcare overall. So thinking about the many different ways of looking at information, let's think about the types of data that might be collected throughout the cycle, whether you're working with whether you're working with EMR data, claims data, or any other aspects like I described on the previous slide. On the previous slide, for example, very important always to look at demographics and geography. We all know that certain areas are more prone for certain diseases. For example, I work a lot with in northern Maine with a cancer council, and in Maine, in the US, which is a most northern, eastern and northern state in the United States, the rate for breast cancer is much higher. Well, this is important to know when you are treating patients, because you want to make sure that you always are, especially when a woman comes in to the office, that you always screen them for that condition. Thinking about conditions and diagnosis and medical health, we don't usually think for women, especially the medical history, because we all think that women take care of themselves, which is actually not true. Women are the least likely to take care of themselves because they are motherly, they feel feminine, they need to be taking care of everyone else except for them. So understanding, truly discussing the conditions and the diagnosis, previous history is very important, and recording that. That is more and more happening now in the EMR side from the physician notes. disease-based scores and indices. So there's many of them for different diseases. Treatments very important because you cannot combine certain therapies or you have to change the therapy protocols in order to be able to treat multiple conditions at one time. Laboratory testing again can reveal so many important information among the biospecimens that you can study and get information or even predict future complications that these patients may have. What is very important is from the self-reported outcomes is really what are the symptoms, how are you feeling? When you wake up in the morning, for example, many individuals might have a low blood pressure, they cannot stand up. They need to eat a spoon of salt in order to stand up. So how are you feeling in the morning? How are you feeling at night? Usually what we are seeing is when you design those self-outcome information in the wrong way, you may actually get the wrong data, meaning people usually feel much better in the morning and much worse at the night. So if you don't think about when these are being collected, you might get, especially for women, after being so tired after 20-hour day, they finally go and sleep, they might be getting you might be getting the wrong picture on what's going on. Disease flare-ups. Very often when you get a disease flare-up, you probably will not report it because you're so sick. So how do we ensure that we correct it and have that information at hand? And then disease prevention. Again, these are notes from the patient, but also very important that physicians review them and provide the insight. So we can bring all of that and really analyze it, right? Which is very important to do the analytics and think about how we analyze that information. One note that I want to mention is this is a presentation about machine learning. I'm not going to be going into these, but many of these analyses right now are all about predictive analytics, looking at the notes and thinking about how can you decipher information from them. So we are applying what's called natural language processing on the data to get the information and put them in a structured way so we can do all of the analytics that we require. There's many different ways of doing that, causal inference, negative controls, which really allows us to compare cohorts and account for the differences. Like the previous speaker was saying, you can look at gender and sex differences, but if you don't code it correctly, or if you don't have the right sample or the right methods, you actually omit a very important aspect of what's driving the care and the healthcare decisions as well as treatments. And then creating a report that can not only help the researchers, but also physicians, and can be published in a way that women can have a messaging created for them, so there is awareness in how we approach them. So the one thing that I want to mention is, which we really don't think about it, and I think that the previous speaker talked about a little bit about the sampling. What's very important is usually when we are thinking about disease-based communities, they are very focused on a special or certain areas, maybe sometimes biased by the locations, because maybe there is a KOL in, let's say, in a large urban area, but it doesn't mean that it presents what's going on in the rural areas. So we have to be very careful about how we are taking findings from these types of studies, how we analyze them, apply natural language processing, or how we apply machine learning techniques on it and do the predictive analytics for what's going to happen in the future or what drives them different decisions at the different endpoints. And think about bringing in claims, which, as I mentioned, healthcare claims is the interaction between your provider or the pharmacy with your insurance. So it's really that chatter that we are seeing, and took it at the both levels. One, closed network, which is within a network where you can track a patient continuously. So if you are, for example, in a one network, you can see the entire interaction. And open claims, which is really bring you up with gaps, but to the larger US population. Because if you don't extrapolate it forward, you'll be only talking about each network at a time. So let me talk about one case study, a brief case study that we are working with a well-known breast cancer association. Being on a board with for Cancer Council and working in Maine to bring more awareness, this is a very dear and near subject for me. Breast cancer is the most common disease for women. It's about 30% of new female cancers each year. Think about it, 30%. That means that as many cancers as they are, breast cancer is the primary one that many women will be faced with, or many families will have to deal with. I do want to mention that while very rare, men also have it. Men also develop it, and I know quite a few patients, male patients who have it. And we have the reverse actually for breast cancer, where treatments are designed primarily for women, but don't account men treatment very well. And in men's situation is very different because there is different tissue and there is different way of structuring body. But I wanted to put in there, and I want to talk from the female side. When there are many investments, still there is not always enough awareness, especially in the rural areas, for the importance of preventive care, doing mammograms, going to your gyno for visits, yearly visits, to make sure that your health is in the right place. So it's very important to really connect the data and work with the patient advocacy groups to understand what's going on there. So we are working with the medical records, like I discussed with you, and we retrieve them and track the patients across many different units. And we think about data curation methods that are the best in class and understand each of the components. But you can see the different aspects of what is the fatty issue, what is the right tissue, what is potentially might be cancer. Understanding the notes and the points in the medical record can really help us understand it. Applying machine learning models such as tree or random forest or many others, depending on the types of data, can help us identify well in advance how in women's medical history, as well as different gyno visits or mammograms can identify or predict with accuracy, or identify points for prediction with accuracy, aspects that we need to be tracking. For example, maybe it's diet, maybe it's use of alcohol, maybe it's medical history, whatever these are, they can be leveraged to provide insights into the future. This is very important when understanding the data and really bringing this in together, because when you don't do it in time, when our physicians, our clinicians and nurses and patient advocacy centers don't have information on what is more likely to drive towards disease development, they cannot prompt, they cannot have the right discussions, they cannot create proactive outreach to certain women groups and family. Men also need to be educated to help and support their female partners when they are going through diagnosis and treatment, to make sure that they get the right support. So all of this plays in a very important aspect to make sure that we provide that care. The other part I wanted to talk about is gynecological diseases. One of them can be endometriosis, but it's actually many other aspects. Usually when you have a gynecological disease, can be very unlikely to diagnose. I think we are much better with other aspects of women's health, but there are some that are only diagnosed when you are going through menopause, and women suffer, and they have infertility issues. They are in a lot of pain, especially during periods, and really their quality of life is very, very, very poor. Usually it is being called that women are emotional, but it's really a painful and very dramatic experience when a woman has to go through that. So again, looking at records, looking at claims data, looking at other information that women's health, you can start connecting these dots and creating models. We sometimes call them what's called typing tools, where you put it in your EMR system, and there are variables that you think is important to help, based on analysis of the data, to help create the alerts for physicians and nurses as they are talking to women, as they are looking at your virus, as they are doing testing, to make sure that we can that we can flag these potential patients at the risks and really start giving them the right care. For women, especially whether it's breast cancer or any other cancer or gynecological diseases, it's very important to do those checks, because if you don't catch them at the right time, the survivorship will be decreasing, but also it's the quality of life. And with everything that women face, if we don't do the proper care, it's going to be very important. It's going to be a long journey for all of us. So, in summary, I hope you learned one thing from from this presentation. Women's health is not very easy. There are so many complex aspects that we need to think about it in a more broad way, how we are really treating a female patient in the office. Two, get the data at the source, but also get the data from many other aspects or many other areas, including consumer data, because the bigger view of how women are thinking about themselves in a healthcare system as well as in the overall economy is changing. Pre-pandemic was very different, during pandemic was different, and we are seeing very drastic change when it comes post-pandemic. When we are thinking about looking at the data, think about looking at the open-end notes from the clinicians. If you don't read them, you're going to miss a very important point. apply natural language processing algorithms on it to get the insights that we really need, and then develop sophisticated or develop even simple models to really start flagging patients who are at risk for any variety of diseases. So with that, I'm gonna stop, and I hope you enjoyed my presentation. Thank you so much for